Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it.
Hi there, this is Dr. Linda Kashaba from Integrative Health. Would you like some help with your thyroid? We would absolutely love to help you out. And guess what? We can even do remote care. Please call us today at 480-657-0003 to set up your first appointment. If you mention code podcast20, you will get 20% off from your first visit. That phone number again is 480-657-0003, and the code is podcast20. Can't wait to meet you.
Hey, Dr. C here with you. So in primary care outpatient medicine, most patients are women, most are females. Men often do enter the medical care system at later stages. But how could it be that the care is not the same if the majority of patients are females? It's a long, shocking story about just how medicine has been too focused on male health and missed the boat in a lot of ways. Dr. Mariza Snyder came and talked to me about this, and I learned that the story was even deeper than I thought. Dr. Snyder's a functional practitioner, and she's written seven really good books. Her most recent one is excellent, the Essential Oils Hormone Solution. She's lectured at wellness centers, conferences, corporations all over for the last decade, been on Dr. Oz, all the big shows. But yeah, great resource. And we talked in real detail about women's health and the state of the medical society and how the findings that we have about women aren't really based on women and how much more we have to learn and understand. So please enjoy the time I had with Dr. Mariza Snyder. Hey, Dr. C here with you for another episode of Medical Myths, Legends, and Fairy Tales. Super excited to be joined by my dear friend, Dr. Mariza Snyder. Mariza, welcome to the podcast.
Thank you so much, Dr. Alan Christensen. I am so excited to be here. I've been waiting for this interview for weeks.
This is such a cool topic. This is super important stuff. I've known for a while that medicine has really done a disservice by thinking that whatever they want to know about women, they can learn by studying men. And we know that that's not true. And you and I have talked a bit about that. You had some wonderful things to share. So yeah, this is really good. People enjoy this.
Absolutely. Well, from the ways medicine is researched and tested to the approach that doctors take on diagnosing and treating disease, more and more research is beginning to show that there's a bias against women in the healthcare system. And not only do women feel dismissed and their pain or their symptoms are not taken seriously, but a lot of them have been reporting a lot of misdiagnosis as a result not only of gender bias, but also doctors just not understanding what is going on with a woman's body. And I have had my own experiences in the healthcare system, not with functional doctors like yourself. Let me just speak to the fact that there are doctors out there that are really looking at women in a different way, are looking at the functional approach to helping women. I know, Dr. C, what is the size of of women in your practice today?
Pretty consistently, 90% or so of our patients, and same thing for readers, mostly female.
I had a feeling. So doctors like yourself who get to see women every single day have a very different perspective as to what is going on and really looking at the deep root of what is happening as well. My first story back in, I want to say about 10 or 11 years ago, I had chronic fatigue. And I don't know, I just didn't know you at the time because I would have been in your office. Instead, I remember a friend of mine had recommended an OBGYN to go and run labs and just look at things, because there's one thing I know about being a practitioner is that you should not diagnose yourself. You can be a little bit biased. So I went to this doctor and she ran labs, and basically they said hormone hot mess on them. Everything was deregulated. But when her recommendations, we really didn't have a conversation. She's like, here's your labs and here's your scripts. And they were birth control and Xanax for chronic fatigue. And I remember looking down, I was devastated. Do you know, I mean, that moment in your life where, like, when you finally get that diagnosis, you finally get validation for what's wrong, and then someone just serves you a crap sandwich for your treatment plan, and you're just like, what is this? And I remember looking at her and looking at these, and I let me just tell you, I did not fulfill those scripts because I knew in my heart of heart, I knew in my gut that that wasn't what was going to get me well. And that really began my pursuit into women's hormone health because I wanted to be a part of the solution and not a part of the problem. I didn't want to be that
Wow.
kind of doctor who was just like, here's some Band-Aid. And honestly, those things weren't even a Band-Aid. They wouldn't have even
Right.
have Band-Aided my symptoms.
Well,
Yeah.
so let's expand a little bit. So one thing is that this doctor was a female. You know,
Yes.
I gathered that part of it. Now the contraceptives and the Xanax. So yeah, I think a crap sandwich would have been safer than a benzodiazepine. We're used in that way. But were you given a diagnosis, or just here, go away, take these, or how did that play out?
It was, here, go away, take these. That was what
Wow.
it was. She's like, well, your progesterone and estrogen levels are very low, and we should regulate them with birth control since you're not on birth control right now. And clearly you're pretty anxious and overwhelmed at your life. So Xanax should probably help you with those moments. That was
Oh
basically
wow.
the solution. And I was like, my first thought was like, I'm exhausted. Like, that's why I feel overwhelmed. Like I'm just trying to muscle through my day and see my own patients, and I knew, many years ago, I had been put on birth control because, when I was really young, that was the thing we all got put on as women, and I didn't really understand the implications. My mom and my grandma used to tell me because I'm Latina, someone could sneeze on me and I would get pregnant, so they had put the fear in me that I should take birth control from an early, I think from 18 years old. And I lasted about 2.5 years on birth control before I just had to finally throw them away because they impacted my mental and emotional function so much that I just couldn't do it anymore. So I knew from the moment that that script was given to me that it was a no-go, that what she was signing me up for was even worse than what I was experiencing at the time.
You know, in Xanax, that's benzodiazepines, the whole class of medications. I'm sure you've seen lots of
Mhm.
folks stuck on them too, and they're tough. You know, there's lots of evidence about structural brain damage, higher rates of fatal apnea episodes, and high addiction potential, liver damage, and they're hard to stop for people who've been on them for a while.
Absolutely. I think one of the biggest concerns was, yeah, what were going to be wouldn't necessarily addictive implications, but how long would I have to rely on these? And I mean, we never looked at my brain chemistry. It wasn't clear that this was the solution for me by any stretch of the imagination. And if it didn't feel right to me, it just wasn't a viable solution.
Right. So this started your path of realizing that hey, things are off, and you know what are some of the things that you started to turn up?
So the first thing that I really looked into was really functional nutrition. I was looking at how do I begin to heal the body, and I also wanted to look at how I was living my life. Alan, I had basically blown through life like a Tasmanian devil, and so it was you can't do that forever, and without paying some consequences. And so I had known that a lot of my lifestyle had landed me in this position. And I also knew that a lot of the stressors that I was putting on my body, whether it was physical or chemical, I was downing coffee and diet sodas like there was no tomorrow, just to get that energy reserve up, just to kind of get me through the end of the day. So I was not making the best life choices for my body every day. And that was compounding over time. So nutrition was super important. I got rid of what I call some hormone sabotaging foods like caffeine and sugar, and gluten and dairy. So cleaned up my diet, really began to put nutrient dense foods into my life, and then started to let go of a lot of the obligations that I was holding on to. I was doing a lot of things that I didn't enjoy doing. I was in committees. I had meetings all the time outside of patients. And I realized I was just signing up for things because I was very much a people pleaser. I just said yes to everything. So those were the lifestyle techniques and changes that I started making that really shifted my energy. energy, actually gave me my energy back. Clearly, self-care played a big role in that as well, and supplementation. I supplemented with magnesium and zinc and vitamin D. I took a multivitamin. I focused on my mitochondrial function, and those were the things that really turned it all around. And there were no prescriptions involved in this protocol.
So when you said the Tasmanian devil thing, I laughed because I know you personally, and I know you're a dynamo, you're a force of nature, so that didn't surprise me. But how did you? Because I know that someone like yourself could lapse on that. You could easily start to creep back into more and more things, more and more commitments. So, what's been the process for keeping things in check afterward?
Absolutely. Well, you've totally nailed it. I mean, you could just like imagine me today 10 times more. That's really what it was then. And so, I will be honest with you, full confession, I can easily find myself back into that default mode of people pleasing, over committing, and just having way too much on my plate. And really, I bookmark my day and evening with rituals and routines that really are sacred for me. And so I don't start my day like that Tasmanian devil anymore. I don't I used to have a timer on myself all the time, and I would time myself in increments of how quickly I could move through activities. And I don't carry
Wow.
a timer anymore. I don't carry a phone near me anymore. I'm not timing how fast I can move through life. And then in the evening, I'm not racing. You can't race to bed. You can't jump into bed, fly into bed, and expect your brain to shut off. I had the worst case of mental chatter. It just would never stop. And so I have this beautiful 30 to 45-minute routine that I will not sacrifice, not even for one episode of The Handmaid's Tale. I will not sacrifice it.
Could you share with us about what that routine looks like?
Absolutely. So my bedroom, we have blackout curtains. There's no electronics allowed in the bedroom. After a certain time, I will tell you, I am recording the podcast in my bedroom as we speak, but all of that gets shut down well before 7 o'clock at night. I make sure that the temperature is set so it's a little bit cool. I eat at least 4 hours prior to going to bed so that my body isn't focused on digestion, because we know that takes a lot of energy. I have a great book that I'm reading. I use my essential oils. I have a diffuser diffusing Roman chamomile, cedarwood, and lavender, which are phenomenal for relaxing the mind and boosting GABA levels. And
Roman chamomile,
Mhm,
cedar, and lavender.
mhm.
Okay.
Not only do they smell incredible, but they are powerful for shutting off the brain. So I have that diffusing right next to the bedside. I've got my book. I don't have any type of blue light coming into my periphery, no electronics anywhere near me. And I give myself basically a good 30 to 40 minutes to just reset, rewind. Sometimes I'll do a little self massage on my shoulders to release tension. And if I'm feeling extra indulgent, maybe I take a little relaxation bath with Epsom salts, sea salt, lavender, and clary sage. So that's if I'm feeling like, again, extra indulgent. So those are my rituals. And I mean, Alex, but Alex super
Yeah,
well, my
yeah.
husband, and Alex will do everything in his power to get me to stay up with him. And he will try to disrupt my ritual because he loves to stay up. And I'm like, I'm going to bed. Like, you can watch that show. I don't care what you do. You can stay up and work on whatever you're working on. This is my time. And I'm usually in bed and asleep by 11 p.m. at the latest because I want my full 8 hours. That I am locked and loaded on.
That's so funny. So that's pretty much me and Karen, except for the opposite. She's always waking up or trying to stay up later or something.
She has told me so many stories about that. She's like, my husband's in bed right now. And I was like, okay.
That totally happens. So you've got your systems down in terms of sleep and relaxation, but you've practiced for medicine for quite a while. You've worked with a lot of people, and you've dealt with the public in many, many ways. What else have you seen about just the ways in which women's healthcare is not doing its best?
Absolutely. Well, it was so interesting. It wasn't until 1993 1993, I just want to just repeat that one more time, that Congress finally passed a law saying that women need to be included in NIH-funded clinical research. And as an aggregate, as we look at that today, we see that women are making up the majority of subjects in NIA-funded research. This isn't private research. This is NIA-funded research. And what we're seeing is that although they look like they're adequately being represented, what's happening is that we're actually not taking women into account. So what we're doing is we're still studying mostly men, but we just add women and stir. They call it the add women and stir approach. So women are
Wow.
included, but are not getting the knowledge that we need.
They're not looked at separately.
Yeah, they're not looking at them separately at all. They're just kind of throwing them into the mix. So even today, in 2016, there was another research article that came out that showed that although women are being studied, much has not changed in what we know about women's physiology relative to men, because we're not separating out that data. We're not looking at it in that way.
Wow.
And again, this is just government-funded research. In private research, we can't mandate private labs, private facilities, private research to actually look at women. So a lot of the drugs still coming out today have not ever looked at the physiological implications of what's happening with women. So it's no surprise that women are 75% more likely to have an adverse drug reaction than men, because we still don't look at them.
Wow. So the assumption that takes place in research is that, and this is just silly to even say it, but is that you could take a young male and subject them to a medication or treatment, and and they assume that it'll work out the same way in a woman's body.
Absolutely. So what they're saying, well, they say one of two things. They go with the camp of women and men are so similar that we do not need to study them separately. Or they go all the way to the other side of the table, and they say that women are so different that it's just too complicated to look at women relative to men or differing from men.
Changing menstrual cycles.
Cyclical every month, or, women are cyclical monthly, daily, monthly, yearly, and then at many phases in our lives. And basically the idea is that it's just not controllable.
This is something I'm not proud of my gender for, but do you know why almost all studies are done on men?
Well, if I had my own theory.
Sure, go for it.
I think it's because men are a lot simpler to look at. And the other theory is, Alan, and I don't think that this is necessarily you, but let's say that you're a man and you decided that you're dictating the research, whether it's in healthcare or whatever it's looking at. And we oftentimes want to study ourselves. We oftentimes want to see what's going on with us. And so if men are running these research studies since the dawn of modern medicine, we have found that there's a gender bias, because it's men who are oftentimes creating these studies, who are oftentimes creating the curriculum, and who really want to know about their bodies more than women.
So I'm sure there's many factors. Yes. One thing I've seen written up, and one thing I've actually experienced personally. So a lot of medical research is basically they'll put an advertisement out, and they want volunteers. And in some cases, they'll recruit people that have a particular condition. But in many cases, for preliminary safety studies, it's not even that. They just want able-bodied volunteers that are willing to do something like take a medication or test a substance for low cost. And the demographic that comes out for those types of things is males who are old enough to consent for it. So pretty much young college-age males make up the biggest majority of that.
Absolutely.
I remember first portions of college, I participated in some patch tests. So just to get some money to buy food, you go to this lab center, and they would put 3-4 little patches of tape on your arm, and then they'd mark the surroundings of that with a marker. And you'd go back and have that looked at every 48 hours. It was to see if you were irritated or had redness or whatnot. And it was all dudes. I don't think women wanted to do that. It wasn't really a great thing to do.
Women were just smarter. Well, the other thing, I interviewed a woman the other day, a doctor named, she's a psychologist, a PhD, and her name's Dr. Sarah Hill. And she had just written a book, how birth control impacts the brain and what we're seeing in brain chemistry. And we actually got into this topic because it's one of the chapters in our book. And what she said is that research is very aggressive, and that there's a really big pressure for researchers to get published very quickly. And it's much faster to study men because they don't have to account for all the hormone changes. They can turn research over faster. So in a competitive scenario where you need to get research out faster than somebody else, it is always easier to study men because there's a lot more things to control than it is to study women.
Mm-hmm. And this has been true in terms of research studies. We also had a lot of issues with diagnosis. A lot of prominent conditions are not really as understood well as they could be medically. I mean, the data is there, but they're often not diagnosed or treated that well. What are some of the big things that you see missed?
Absolutely. Well, I think definitely hormone driven conditions, right? And autoimmune conditions are big ones. Anything where we see a women are really struggling. We also see things like pain and heart disease. So often we don't really recognize the symptoms for women when they're having a heart attack. And there's been research that if women are under the care of male doctors, in these instances, they could be sent home literally in the middle of a heart attack. Now, that doesn't happen often, but it has happened enough that it has been cited in multiple journals. So those are some of the things, oftentimes a lot of our symptoms as women, whether it's pain or it is hormonal symptoms or it's autoimmune type of conditions, we have always been taught that it's somatic, that women are making it up in their head. And that really brings us to a lot of the history of women's healthcare from the very, very beginning. And we talked about this when we met a couple days ago, but Hippocratic medicine back from the 5th century said the womb was the origin of all diseases. And in that time, hysteria, from the Greek word for uterus, was to blame for all common inconveniences, such as menstrual cramps and dizziness, as well as life-altering misfortunes that could potentially be pain, suffocation, or even paralysis. Basically, everything was blamed on hysteria, which was a wandering womb inside of the body, which we talked a little bit about together. And although that diagnosis left in the early 19th century, unfortunately, it still largely attributes to the fate of women in the healthcare system.
Well, the bias is really just that even now they don't believe the uterus wanders around like they did before, they still think that these things that are happening for, we talk about someone being hysterical or being just overly emotional. And we're not thinking that there could be real issues happening in the same way.
Absolutely. So, they thought hysteria was considered pretty much an organic disease, which within all women. So all women had hysteria at some point. And like I said, this theory guided a doctor's practice from the late 19th century to the early 20th century, and basically held that women's normal state was to be sick. And we still see that languaging, like, oh, you're being hysterical, or, she's a hysterical patient. And we see that so often. And it was really interesting. If we look back at menopause specifically, in 1966, Robert A. Wilson argued in his book, Feminine Forever, that menopause was a curable state that no woman need to suffer thanks to treatment with supplemental estrogen. And what we knew, yes, it was a disease, by the way. Menopause is a disease that we need to treat with synthetic hormones.
Was this about the time of diethylstilbestrol? Or?
Yeah, exactly. Before this time, late 1940s, early 1950s, as far as doctors and the medical literature showed, is that women did not have symptoms related to menopause. It was all in their head. But once menopause became a big business, American women were told that their symptoms were now proliferating. Like they had a lot of symptoms, and that they had to use hormone replacement therapy to actually fix it. So women went from no symptomology at all, and it's all in their head and they're crazy, to these symptoms are real and that they must treat them with hormone replacement therapy.
Oh, wow. And the versions of that changed over time, but
Oh,
that
yeah.
persisted for quite a while.
Yeah, well, in short, so what has happened in today's medicine, it's really interesting because these are two very contradictory extremes, right? That medicine has tended to vacillate between. So either women's reproductive function was either completely normal or innately abnormal. And what that's really settled into today as the position is that we have kind of incorporated the worst of both worlds. So it's considered normal for women's reproductive function to be a bit abnormal. That's what we normally typically believe today. And if it's really, really bad, then it's definitely possibly still in their head.
Oh, wow.
So Alan, so you can have menstrual cramps. Well, not you, but let's just say Karen does. And I can have menstrual cramps. But if my menstrual cramps become so severe that I'm not able to function, then that's most likely somatic. It's mostly in my head.
Really?
Mm-hmm. At some point,
That's ridiculous.
yeah, at some point it's just okay. We're like, and it was interesting. I was reading the book by Maya Dunsenberry, which talks about how lazy science and bad medicine have left women misdiagnosed and mistreated. And she talked about how very often women today are considered chronic complainers, and that they get notes in their files, in their medical files, and that's brought from doctor to doctor to doctor. And there have been so many cases of women who've been marked as a chronic complainer, and they just get dismissed after dismissed after dismissed without any resolution as to what's going on with them.
And I'm not sure how this plays out exactly, but there are differences in the sense that when there are real symptoms, perhaps women are doing appropriate reporting, but then men do report less. Many argue that men probably do underreport a lot of symptoms.
So true. I think oftentimes the reason why men end up getting to the doctor's office is because of their partners or their wives.
That's so common.
It's very common, right? I'm sure if you ever get a male in your office, it's because the wife, referred them. I mean, even Alex, who's so great about wellness, I make up his supplemental package, like his little supplement box. He won't take them unless I put them out. And that's pretty crazy. Still, I've been doing it for years, and like I said, he's much more proactive than a lot of men I've ever met. But that's kind of my role in this relationship, is to make sure we have the right foods in the house, make sure we got all my supplements, and make sure we're taking care of our bodies.
To be really precise, most of the men that come in, their wives, their spouses, they don't refer them; they physically bring them.
Yes,
absolutely. And they often do a lot of the talking for them too.
Yeah, so he's got this and this, and last week he had this. Oh, and did you?
And he won't tell you this, but this is going on too.
Exactly. And so it's so interesting, this kind of the flip side of, women being open to sharing what's going on with their bodies. They're more aware of what's happening in their bodies. And this isn't always the case. But in these instances, they're not necessarily always being believed. Mind you, things are shifting, but we still have a ways to go, even within the medical curriculum. I'm not sure if you can remember back to what you were taught. I don't remember distinctively being taught the difference between like how women's physiology functioned opposed to men, unless it was through fertility or reproductive health. But I really want to start seeing more of a curriculum embracing the fact that women's physiology is different than male physiology. And we're just not seeing that even in the early stages of medical school or naturopathic school or whatever school people are going to get educated.
Back then, just what you said, when it did come down to reproductive health and pregnancy, and a little bit in terms of menopause and the implications of that, but otherwise, no. And I think there's just a lot we have yet to learn about those distinctions of physiology.
Mm-hmm, absolutely. And it was interesting. I was talking to a dear friend of mine, and he's an integrative MD, but he wasn't for a long time. And he said, when I was in medical school in the 80s, he said the number one prescription for menopause. Like the second a woman mentioned menopause or perimenopause, he's like, the protocol was to prescribe synthetic hormones. He's like, we didn't even think about it. And that's just what we did over and over and over again. And
Well, that was Premarin then.
yeah, it was Premarin. Yeah, it was definitely Premarin. And then, and then all the research was coming out about Premarin, and so many people had stopped. And there's still a lot of gray area in that. But he was like, this is how far, we still need to be looking into this. Like this was not okay. And we just took it in blind faith. This is what we needed to do for these women.
Well, and we just briefly mentioned DES or diethylstilbestrol earlier, and that was used for vasomotor symptoms of menopause, but it was also used for many symptoms of pregnancy. It was given during pregnancy back then. And the weird thing is that, hormones are specific compounds that act on hormone receptors in the body, but there's a lot of chemicals that are not hormones, but can still act on those same receptors in various ways. And that's why there's all these things that are not like what the body makes, but can have some similar effects. And diethylstilbestrol is one of the first examples where we realized how bad that could be. We now know that 3 generations, that not just the women given diethylstilbestrol, but their granddaughters have higher rates of diseases, specifically very rare vaginal cancers. So it was so harsh, it affected women for 3 generations consecutively.
Well, and that really demonstrates the power of epigenetics, right? And how much we can, what happens to, women and, whether your grandmother, your great grandmother, and how that is passed down generation to generation. My mom remembers when my grandmother was put on Premarin and a tranquilizer. She was given Valium or some type of tranquilizer. My mom and my grandma don't specifically remember. My mom says it was literally like night and day. One day my grandmother was my grandma. The next day she was like a zombie. Like
Wow.
It was like someone had given her a prefrontal lobotomy. My mom said she was a fraction of who she was within 24 hours.
And when I started practicing, this was the very, very earliest days of natural hormones. It was just before John Lee had his book about, which are documented about progesterone, and read about when Jonathan Wright made the first Triest formula. And back then, women were still all on Premarin.
Mm-hmm.
And it was actually an argument to persuade them that it was a bad idea. And the most effective strategy, this was the funny thing, to help them realize how harsh this stuff was, I wouldn't even argue. I would just ask if they had it with them. They often did. And the trick was you take a cup of hot water and drop a tablet in a cup of hot water and just let it sit there, real close by as you were talking. Do you know what happened?
I have my thoughts, but what happened?
Well, so Premarin is pregnant mare's urine.
Yes, it is.
It's a horse's urine concentrate. So when that hits in hot water for a couple of minutes, it's pretty aromatic. And then you talk about where it comes from, and that usually seals the deal.
No one's like, I am not consuming urine. That's not going down for me.
And if you talk about that in the context of the odor of it, then it's really straightforward.
That's so funny. We think about our sense of smell is directly connected to our sense of survival. So it's no wonder that you were able to convince someone to stop taking that after they smell it. They're just like, oh my God, that smells dangerous. That smells like I shouldn't consume it. Yes.
Well, it's the insular cortex, the whole sense of disgust, and it changes psychology. Well, as much as positive essential oils can boost it, harsh negative smells can send you the opposite directions.
Absolutely. Well, I'm so grateful to our sense of smell. You can smell. About a week and a half ago, I was in the middle of a podcast interview and I could smell gas. And we had a gas leak in the house. And we had a bunch of my team was here. And so, like you're sitting there, you're like, what's that? And then I'm like, what's that? And so I ran out of the room. We had to clear everyone out of the house. We had to leave the house. It took 24 hours later, we were able to finally come back after everything was fixed. But so grateful for our sense of smell, to be able to pick that up and say, what is that? And you definitely leverage the sense of smell, whether for a really wonderful beneficial experience like aromatherapy before going to bed, or just something noxic that you need to get out of the house for.
We'll be right back after a word from Integrative Health.
We hope you're enjoying this episode of Medical Myths, Legends, and Fairy Tales. This is Dr. Raquel Espinal at Integrative Healthcare. You know, so often we hear from our new patients that their primary care physician has told them that their thyroid and hormone levels are fine and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help and there is hope. The doctors at Integrative Health, including myself, specialize in naturally treating your thyroid, your hormone, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, you can get treatment with one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use the code PODCAST20 for 20% off your new patient visit. Again, that is integrativehealthcare.com and use the code PODCAST20, all one word. Get back to the road to thriving. We look forward to seeing you.
And now, back for more medical myths, legends, and fairy tales. You know, one disease state you mentioned is really representative of some of these issues. Could you tell us a bit more about how endometriosis is not well diagnosed or treated?
Absolutely. Well, I'd love to go a little bit into the background about endometriosis because it's still a condition that we are still struggling with in the medical community. You know, the first treatment of endometriosis was pregnancy. That was actually, that's how we treated women in general. We're like, could you just get pregnant?
Oh, wow.
And so was hysteria, the same as hysteria. So if women were exhibiting signs and
Pregnancy is a treatment. Okay.
pregnancy
Wow.
was the treatment. Yes. And it was feared that endometriosis was on the rise due to the delayed and infrequent of childbearing. And doctors urged that women be taught how to become pregnant and how to not avoid pregnancy. By postponing pregnancy, they felt at an early age, women were defying nature's rules. And so that was their punishment for defying nature's rules, is that they would suffer horrible endometrial pain in their pelvic area through endometriosis. So that was the beginning. This was in the early
What was the early 1900s? Okay, so was there some medical reason, or was this like an attack or a retribution from, I don't know, some spirit or deity, or what was the thought process?
It's just that women were not doing their jobs in the household. They were not rearing children. They wanted to start creating careers, and this was punishment for that, for not in their natural order. So, fast forward to the 1960s, which again wasn't that long ago, right?
Right.
Endometriosis was considered a career woman's disease because more and more women began to flagrantly break nature's rules and enter into the workforce. And the typical patient, as far as doctors in the medical literature showed, they were underweight, they were overly anxious, they were intelligent, egocentric, and they were perfectionists. They were the type of women who would put things exactly back in their place. And that was in medical literature. That's what you should be looking out for. Women who
Wow.
were so perfectionistic. And it was the idea that endometriosis was a disease of the mid-class, white, educated women who had postponed childbearing in favor of a career. And that idea around endometriosis persisted into the 1990s. And what
Oh
we
my goodness.
learned, yeah, it was so crazy. So basically, this stereotype that women were being effectively blamed for bringing the disease onto themselves with their selfish life choices. And this carried, again, up until the early 90s. Now, this myth came about because this is what they were looking at when you look at causation, right? We see these women being diagnosed. It's a very specific type of woman. And this myth came about because it was really only educated, affluent women who forced doctors to diagnose them. After many, many, many doctors, they were the ones who not only had the financial capabilities to get the diagnosis, but also they had the finances, that persistence, that they could pay for the procedure performed by very few specialists. And they also had enough authority to convince doctors that their symptoms were really abnormal and not just normalized menstrual pain. Because let's be honest, all of us, my mama told me that my severe menstrual pain was normal. I grew up believing that menstrual pain was just a fact of life, that this is something women had to deal with. And so this was exactly what was happening in the doctor's office, that women were getting normalized as menstrual pain. And one of the things that I had told you when we got together is that only white women were showing up with an endometriosis diagnosis until after the 90s, so early
That's
2000s,
right.
because racial minorities didn't get that endometriosis diagnosis, because if an African American or a Mexican woman went to the doctor with this very same symptoms as a white woman, she was told that she had pelvic inflammatory disease, and that was due to her sexual promiscuity.
Wow.
So it
So the
just
exact same symptoms, but
Yeah,
yeah.
exactly. So there, it's not possible. You don't fit the criteria. You don't fit the cause and effect. This doesn't apply to you. And what we know today, and this is still today, is that it takes a woman an average of 7 health specialists or doctors and 10 years to finally get an official diagnosis. And as you and I both know, with endometriosis, to actually get an official diagnosis, they have got to go in surgically and
Yeah.
see if the lesions are there, like insight with laparoscopic surgery. And so it wasn't until, I want to say, 2006 that that we started looking at endometriosis. We started even doing research on endometriosis. Right now there's about $10 million devoted to endometriosis research, which you and I both know is a drop in the
That
bucket.
might do one small study.
It's a tiny study. It's like no money.
Yeah.
You think about cancer research, just billions of dollars devoted to cancer research today, and then $10 million for endometriosis. But it wasn't even until 2006 that there was a medical conference on pain and endometriosis, because how they were rating endometriosis, and I think still to this day, is that we all know that endometriosis can cause infertility. So how we measured it is a woman would be ranked with a very severe case of endometriosis if it impacted her infertility, and then she would be considered a case worth treating and working on. But if a woman only came in with endometriosis and pain and her infertility wasn't impacted, they would just write it off as a psychological somatic issue. It was all in her head. So they didn't actually believe that women with endometriosis even experienced pain until the early 2000s.
You're kidding.
Mm-mm. Yeah, and
I
I'm
didn't
not
realize it was
saying,
that recent.
yeah, it's so, and I'm not saying this is as an entire whole, but as we look
Right.
at the medical literature, that is where we stand right now. That even till this day, most women as teenagers and young adults, they go to their OBGYN, or they go to their primary care doctor. This is typically how it goes. And they complain of really bad menstrual cramps. And those doctors give them Midol or ibuprofen or birth control to regulate these menstrual pain, and just write them off, send them off on their way. And it's not until their mid 20s to even potentially almost 30 years old that they finally officially get the endometriosis diagnosis.
For some of our listeners, could you just briefly explain what exactly this condition is and what it entails?
Absolutely. So and I will tell you that as the medical literature still stands, they're not very clear as to why women get endometriosis. Now, there is a theory forming that I strongly support, in that endometriosis is going to potentially become an autoimmune condition. That's where I stand on that. And I've read a lot of the research and literature, and I'm feeling pretty confident that it meets a lot of the criteria, if not all the criteria, of an autoimmune condition. And when you follow protocols like the autoimmune protocol, we see a significant reduction in endometrial symptoms and inflammation. So this is basically what happens. We know that endometrial tissue, this is tissue inside of the uterus that we shed every year or every month during our menstrual cycle, somehow gets out into the reproductive area, whether it's on the ovaries, the fallopian tubes, and even just all around the pelvic region. And we know that it's exacerbated by estrogen. So especially in the follicular phase of our cycle, as estrogen is beginning to rise, as we get close to ovulation, is when we really begin to experience intense pain. But what's interesting is, although the endometrial tissue, we're not exactly sure how it's getting out of the uterus into the pelvic area environment, we know that it's the immune system that is hyperactive and actually creating kind of going after this endometrial tissue, creating massive inflammation and lesions in the area, which is then exacerbated by our hormones. So although endometriosis is considered right now kind of a hormonal condition, we have to look at the implications of the hyperactivity of the immune system upon which it attacks the endometrial tissue.
In autoimmune disease, many of them have rates of comorbidity to where if you have one, you'll have higher risks of having the other. And there has been data saying that those who have thyroid autoimmune disease do have higher rates of endometriosis. And I've seen a little data too saying that there may be some tissue abnormalities in thyroid hormone response within endometriosis. So yeah, you've got these cells that are not where they belong, but it seems they also have some distinct patterns of thyroid hormone metabolism. The ovarian tissue and some of the uterine tissue itself is highly responsive to T2, which is not as common, but there's deiodinase enzymes that are distinct in endometrial tissue in endometriosis that are not true for healthy endometrial tissue. And apparently there's alterations in T3 response and T4 accumulation in endometriosis.
Which is so interesting. I've been just barely kind of scratching the surface of that connection between Hashimoto's thyroiditis and the way that the immune system is targeting that tissue versus endometriosis and then other autoimmune conditions. Lots of women, when they look at endometriosis, then come out recognizing that they have other autoimmune conditions as well. Well, and not to say that endometriosis has been designated an autoimmune condition yet, right, but I have a feeling that that's going to be coming down the pike.
Yeah, and the overlaps there for Hashimoto's and for Graves' disease.
Yes, absolutely. And for Graves' disease. So it's no surprise that still to this day, Alan, doctors are still recommending pregnancy as a treatment for endometriosis.
Oh, really? I didn't know that.
Yes. I just want to let you know that doctors are like, so have you thought about getting pregnant? Maybe we can get rid of this, which is super, super crazy to me because that may not be the thing that particular woman is looking for. And a recent study in 2017 looked at general practitioners and found that nearly 2/3 of them said that they are not comfortable diagnosing endometriosis. And most gynecologists don't get a lot of training because it requires a surgical diagnosis of this disease. So there's a lot of still not only unknowns, but a lot of doctors that are just not feeling comfortable. And then a lot of patients that are just not, that are being told that a lot of their symptoms are normalized or that they're just making them up. So we have a compounding of a couple different things happening all at once. And I think it has a lot to do with the fact that there's a lot of mystery around endometriosis and it's not clear the cause. It's so interesting to me. For hundreds of years, pain in menstruating women has not qualified as a medical mystery worthy of solving. That's where we're at today.
Wow.
We just don't seem to care.
I guess. Well, a lot of what we call caring comes down to funding, and that comes down to a pill that a lot of people are going to take for a long time. So if there were some causes that were found and addressed, that might not be something that would require long-standing treatment.
Absolutely.
And menstruation and that level of symptomology perhaps is not thought to encompass a large enough number of years to be of interest. I don't know.
Agreed. Yeah, it's really interesting as you look back, not only at the history as we really dove into today, but also where we stand present day as well. And, I think a lot of it is that we still believe that a lot of it's in our heads, or doctors believe a lot of it's in our heads, that maybe we're not suffering as much as we claim that we are. And if as long as women are still fertile and they're still able to get pregnant, which is, I guess, kind of the number one goal for women, we're okay with it.
So one thing is just menstrual pain, realizing that if you're experiencing that, it may not be a normal level. It seems like it's a lot. It might really be a lot. There could be something wrong. What are a few other symptoms in general that you think are too readily dismissed?
Oh, that's such a great question. I think pain overall is a symptom that's readily dismissed. I think that oftentimes when women come in with pain, and I can't pull all the research up right now, but that's one of the biggest areas that we've looked at around women is how often women are misdiagnosed for their pain. Autoimmune conditions, Hashimoto's thyroiditis is such a great example of that. I got diagnosed just last summer, and I know for a fact that I had Hashimoto's for at least a couple of years prior to that. And initially my labs relatively looked normal, and definitely I had better doctors than most. I had great integrative doctors, but we just kept missing some pieces. Even the antibodies didn't look too bad at the time. But so often when we're looking at diagnosing a hypothyroid or a thyroid condition, you know better than I do that a lot of times at the doctor's office and and medical institutions, our our values, the normal ranges that we're looking on are so wide that we continue to miss them. And we look at things like TSH, which is a pituitary hormone, not the actual hormones themselves. And so I think autoimmune disease is misdiagnosed a lot. Pain is misdiagnosed a lot. Cardiovascular disease, so women actually having a heart attack or
Chest pain.
yeah, chest pain, or where it may not even actually be chest pain. Maybe it's like kind of a numbness or a headache that they experience, maybe around their jawline. It just, the symptomology shows up a little bit different. Those are some of the biggest things that I saw in the literature: is cardiovascular, heart attack, pain, autoimmune conditions, and then clearly hormonal driven conditions.
So symptoms related to the cycles, to perimenopause, to menopause.
hmm to pain. And we know pain can come from a lot of different things, right? Whether it's acute, mostly chronic pain is what we're talking about in this particular instance. It's just that we tend to believe men when they're dealing with pain. We have a difficult time believing that women are dealing with pain. We think that maybe they're just over exaggerating it.
You know, we were talking earlier about just that gender difference and how men, if anything, may underreport. I wonder if that's part of the issue as well, is that with a lot of healthcare, I think now that's changing as far as the percent of doctors and their gender. I think that's different. But I think a lot of the formative years of healthcare, it was clearly male dominated. And perhaps a lot of the guidelines were based around people that were underreporting symptoms or a lot of the levels. Yeah.
Yeah, absolutely. And women have spoken. There's been a lot of different foundations and organizations that have, even within medical school, female practitioners getting together, and they are really trying to turn the tide of what is happening. But it's a slow process. As much as we're so grateful that a lot of decisions were made in the 1990s. That's when a lot of things began to change in terms of looking at women in medical studies and drug testing studies, what the government could control. But even still, it's been reported that a lot of things haven't changed as much as we would like to see. And the big solution that they say really has to start with the schooling, the emphasis on looking at women's physiology in a different way. So it gets us to be more open-minded to kind of seeing it in practice.
So as things are evolving and as they're catching up, so the bulk of our listeners are going to be female. What do you want them to hear as far as things they can do to really be better advocates or help navigate the system more effectively?
Absolutely. And let me speak to the sensitivity of advocating for oneself. It can be very intimidating and it can be very scary to go into the doctor's office and sit there in a gown, very, very vulnerable, and demand something different when you have a doctor just telling you what like it is. So I just want to speak to that very quickly. I've been in that scenario where, a lot of things were happening to my body at once, and I felt like I didn't even have a voice. And I'm a really great advocate. So I've been the person who sat as a family member, or like kind of the family practitioner, to come in and advocate for my family's care. But then when I was on the table, I just felt like I completely lost my voice in that moment. So I just want to speak to that. But this is, unfortunately, it's the thing that we've got to do. We've got to use our voice. We've got to be, I always say, have women take a piece of paper, have your questions on paper so you can see them, that they're a cue for you. So be prepared to ask these specific types of questions. So when you're prescribed a medication, if you are at all, ask your doctor if that drug was ever studied on women and whether it has potential side effects for women. And if they don't know, whether you could decide to go somewhere else, ask for a second opinion, or maybe hold off on taking that medication until you do your own research. It's up to you there. But it's worth asking the question to see if there's any information on that medication for your body. The next thing I recommend is, if you're told to get a specific medical test, you want to know how accurate it is for you as a woman as well. Many common diagnostic tools were designed only around men. Ask for tests that have been studied on women, or that we know can actually show results for women. And then when it comes to assessing your body and your health, always listen to your gut. Listen to that inner wisdom. My message to women is to be willing to look for a second or third opinion and be willing to walk away from a partnership that isn't working for themselves. Then most importantly, consider working with a functional practitioner, because they're going to be looking at the root cause of disease. They're going to be looking at integrative steps. And a lot of the functional medicine, I believe, has looked more at women's bodies, has looked more at getting to the root cause of what's going on with them. And I think that they're going to have a more integrative plan. And then last but not least, I think we should always be asking why. When I got my diagnosis for Hashimoto's, I wanted to know why. I wanted to know, okay, what? Because my thyroid didn't just decide to not act right. It's a victim of circumstance. My poor little thyroid is getting it's unfortunately being targeted. I want to know why. What was the driving factor there? Was it stress? Was it latent infections? Was it gut issues? Was it trauma from when I was younger? What were the driving forces, or what are the driving forces for my condition? Because what we know, and you may know this stat better than I do, but when women go in and get diagnosed with hypothyroid and they're put on a synthetic T4, whether it's levothyroid or synthroid or whatever it may be, and they're just sent on their merry way to go take this medication, that inflammation doesn't go away. It continues to smolder inside of the body. And I believe that women who are on thyroid medications have a significant, I think it's a twofold chance of getting diagnosed with cancer over the next 10 to 20 years, because we never addressed the root cause of that issue. And it proliferated somewhere else. So I think it's important to be asking the question of why. Why, doctor, why do I have this? Why is it this showing up for me? And hopefully they've got some answers for you. And if not, there are a lot of doctors who will have those answers for you.
That's super awesome. I love all of that. One thing that I'm not sure if you've heard or not, I just want to share. If you've not, I'd love for you to mention to your people as well, in terms of testing not being done well for women and thyroid disease. So often people will have their thyroid tested repeatedly if they've been previously diagnosed, if they're on treatment, they're suspecting it. And there's often a lot of confusion raised about levels fluctuating. And a problem is that in many times, if you're testing in ways that are inconsistent, it can cause fluctuations that are not meaningful. And one of the biggest ones that I just never, ever hear women being told is that women who are regularly menstruating between days 10 through 20, their thyroid levels will not be accurately measured. They cannot get a decent measurement done.
You're absolutely right. Yeah, they definitely can. And no one tells them to not test on those days. Also, and you can speak to this as well, when women are on synthetic thyroid and they're just looking at the thyroid stimulating hormone, we know that that's not going to be accurate information. And so I feel like women aren't told, when to take their medications before they get tested, how long between the medication and when they get tested, how consistent they need to be getting tested around the same time every time, like those, or even for hormone tests. So often, women are,
for sure.
Yeah, they're never told to test between, day 19 and 22 of their cycle, or if there's just a lot of inconsistencies when we're looking at testing that lead to incorrect answers and diagnosis.
Super fast for the listeners, for a recap who haven't heard it, here's the 5 rules of getting an accurate thyroid test. So you've got to do it between 7 to 9 in the morning. It's a circadian hormone. You've got to get it fasting. The food skews it. You've got to do it before taking any other pills, including especially your thyroid medication. You take your thyroid medication after the blood tests. The menstrual cycle, you can test between days 1 through 9 or days 21 through 28. If your cycles are erratic, test in the first week after your period starts. And the last one is biotin. So even a few hundred micrograms of biotin doesn't hurt your body or your thyroid, but it changes the lab reagent's chemical response. So you need a 72-hour window after any pills that contain biotin to get a decent test for TSH, T4, or for ferritin. So those are the big 5 rules for testing.
Oh my gosh, thank you so much. I love those little tidbits, right, that we get to bring in. I did not know about biotin. All the other ones I did know. But I wasn't, didn't have my mind cued into the biotin reactivity.
For a long time, we thought that megadose biotin was harmful to the thyroid. We thought that was like 10, 20,000 micrograms, which most folks didn't take. Mm-hmm. But now we've recently learned that it's not, but it's more so interacting with the reagents in the laboratory. So yeah, even smaller amounts can do that. So someone, if they have all 5 of those variables in different ways when they test, the results are all over the place in just ways that are confusing.
That makes so much sense.
So that's really cool. So we got some great ways that women can advocate and ways to be more informed and think more thoroughly about symptoms and not thinking that they should expect to have ongoing menstrual pain or these things persist. There should be some explanations they can find for it.
Absolutely. And I think the answers are out there. The one thing I do want to bring hope, because I felt like I may have been a little bit of bad news today. It's important that we know these things, but the hope is that number one, your body is ripe for healing miracles. I want everyone to know that. And number two, you're not alone. And there are a lot of doctors who are doing the good work out there. And I know that they might not always be in your area, but I promise you that they're out there and that they are willing to advocate for you as well. So just know that to be true. I wouldn't have dropped all of the truth bombs on you today if I didn't know for a fact that there were doctors out there doing the good work that will really have your back. So I just wanted to make sure that that was known as well.
I'd really encourage everyone to connect more with Dr. Mariza, drmariza.com. We'll have all the links in the show notes. She's got a great book that I read before it came out, and I highly endorse, about how you can use safe essential oils to improve your hormone health. But lots of great resources there and lots of great social media things as well. So please do connect with Dr. Mariza.
Thank you so much, Dr. Allen. It was such a pleasure to come on.
Great to hang out with you again. And those who are with us, thank you for joining us. And I'll see you again real soon on another episode of Medical Myths, Legends, and Fairy Tales. Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much, and I'll be back with you real soon. Bye-bye.